Good evening, Anand. All the best.
Where are you?
Good evening, sir.
Good evening, Inder.
How are
Hi,
you, sir?
Anand. All good. How are you, Anand and Inder?
All good, sir.
Very nice.
Good evening, Naveen sir. Nitya speaking.
Hello.
Nitya from
Good evening.
Brahmi, sir.
Good evening. Good evening.
Good evening, sir.
Hello, Dr. Prateek.
Hello, Pratik.
Pratik sir is muted, I think.
No, I think my laptop is muted, but
Okay. Right, sir.
Can we start, sir?
I think there's still a minute, so
Okay, sir.
I start, Inder.
Please, sir, just give me 1 minute. Good evening, everyone. We welcome you all again on day 5 of the webinar series. Today, we have a very eminent chairperson, Dr. Naveen Sankhya, sir. Sir is my teacher and my mentor. Sir did DM Pediatric Neurology from AIMS Delhi, and sir is currently Additional Professor and Chief of Pediatric Neurology Unit in Department of Pediatrics, PGI Chandigarh. He is Medical Superintendent of Advanced Pediatric Center. Sir has around 200 publications in various reputed national and international index journal in each credit, and he authored more than 35 chapters in various textbook of pediatrics and pediatric neurology. He's principal investigator in various national and international multicentric trials, including the Autism trial and the role of virtual reality in hemiplegic cerebral palsy. Such areas of interest is neuroimmunology, neuromuscular disorder, and neuroinfections. Now I would like to request the chairperson, sir, to introduce our speakers and to start the today's session.
Thank you, Inder, for that introduction. We have two very good speakers, and the topic also is very pertinent for all practicing pediatric neurologists, and also there are topics which are important for practicing pediatrics as well. So the first speaker is Dr. Anant Narayan, who will be talking about Guillain-Barré syndrome. Dr. Anant has done his DM in pediatric neurology from PGI Chandigarh. He's currently working as assistant professor in the Department of Pediatrics at JIPMER, Pondicherry. He is a thorough academician and a very good researcher. He has more than 50 publications in national and international journals, and he's authored various books in reputed textbooks. He has been invited as speaker for many conferences, and his area of interest is Guillain-Barré syndrome, cerebral palsy, neuroinfections, and also epilepsy, if I may say. So over to Anand for a quick overview of Guillain-Barré syndrome.
Thank you, sir, for your kind introduction, and a very good afternoon to all the participants who have logged in. The topic of today's discussion is Guillain-Barré syndrome, and we will be focusing on 4 important domains. One is the clinical features of GBS and its variants. We'll also discuss its pathogenesis, the diagnostic approach, and also a word about treatment and its overall prognosis. Before we start, we'll have a little flashback in time. The first objective description of Guillain-Barré syndrome was in the year 1916 during the Battle of Somme in the French army, when neuroscientist Guillain-Barré and his associate Stoll had described 2 soldiers with weakness of limbs. The description was very archetypical and they were very precise in nature. The illness had begun with tingling of feet and weakness of lower limbs, which made them stop walking for a period of after 200 to 300 meters. And in the subsequent days, the tingling had spread to the upper limbs and lower part of the face. This was in the year 1916. And over the last 100 years, there has been tremendous progress, I would say substantial enough, in the management of Guillain-Barré syndrome, starting with the establishment of the clinical criteria in 1976 to establishment of plasma exchange as one of the important effective modalities of treatment in 1984, and GBS IVIG trial of 1992. Almost in the fact in 2016, GBS was strongly linked with Zika virus, and now the current pandemic of COVID-19, there have been anecdotal reports in major publications where association of Guillain-Barré syndrome and COVID-19 have also been published. So with this short introduction, what exactly is GBS? GBS is the most frequent cause of acute flaccid paralysis worldwide. It is one of the serious emergencies in neurology and pediatric neurology. However, there are 2 major misconceptions with regards to GBS. One, it may look as a fairly simple disease, but it's not so. It comes under a rubric of peripheral nerve disorders. Each have their own distribution of weakness, and their underlying pathophysiology is quite varied, and sometimes it's very unclear as well. And another misconception is GBS has a very good prognosis, which is not exactly true, as up to 20% of patients remain disabled, and approximately 5% die despite immunotherapy. These 2 misconceptions are very common. We will discuss about these things over a period of time. So how is the epidemiology? In children, it amounts to around 0.3 to 1.3 cases per 100,000 person years. Males are predominantly more affected than females. And more importantly, almost 2/3 of the cases are preceded by symptoms of upper respiratory tract infection or diarrhea. There has been no significant seasonal fluctuation, and more importantly, there is no clinically relevant association with vaccine of now. There was a panic in 1920s with influenza vaccine and GBS, and also in 1980s, but it is no longer associated. So what are the frequent antecedents which are responsible for GBS? One, predominantly infection in nature, known as the Campylobacter jejuni. Apart from that, we have a cluster of viruses like cytomegalovirus, Epstein-Barr virus, and varicella. And in the last 10 years, there has been tremendous input over hepatitis E infection as well as Zika virus infection. Apart from that, sometimes there may be associated with more than one infections as an antecedent event, as this publication had rightly pointed out. The majority of them had Campylobacter jejuni, but they also had a little bit of other viral infections as well. The clinical journey of Guillain-Barré follows a very typical pattern. It can be easily divided into 4 important phases. One is the phase of progression, followed by a plateau phase, followed by a recovery, and also by disability. As you can clearly see, the progression of the weakness is over a period of weeks, and usually the maximum nadir or maximum the severity of weakness is by end of 4 weeks. Following which, there is a plateau phase where there will be no progression. And over a period of months, starting from 2 months to around 6 months, there might be a slow recovery, and some amount of disability is noted even after 3 years of the onset of the weakness. So what exactly is a typical GBS pattern? As you can clearly understand from the first description, it was a rapidly progressive disease, which was bilateral weakness of legs or arms. It was ascending in nature. It had progressed to arms and cranial muscles. It is associated with distal paresthesia or sensory loss, which is quite uncommon to be heard from children. They may also have unexplained muscle pain or radicular pain, and they usually do not have any CNS involvement. From examination point of view, a typical GBS will have reflexes which are hyporeflexic or absent. They also have dysautonomia, which is predominantly in the form of heart rate variability or BP instability. They may or may not have bowel bladder dysfunction. And maximum disability of the illness is usually attained in 90% by around 2 weeks of onset. And 30%, mind you, 30% is a huge number, 30% require ventilatory support, and 80% recover by 6 months. This is the archetypical presentation of the classical GBS, which amounts to 35 to 80% of the GBS in the world. But when it comes to children, especially less than 6 years of age, the scenario is quite different because they may present to us with non-specific features like poorly localized pain, refusal to bear weight. They may also present you with unexplained irritability or unsteady gait. Sometimes they may present you with features of meningism as well. Given the typical features, there are a few atypical forms of GBS as well, where the onset of the illness might be, where the presenting feature might be a diffuse pain. They may not present with ascending weakness to begin with. Sometimes they might have intact reflexes. So the dictum that GBS has to be associated with hyporeflexia or diminished reflexes is no longer in consideration. Sometimes 20% of them, especially in children, will have intact reflexes. Sometimes their presentation may not be very typical as an ascending one, where proximal will be more than distal, and the onset of weakness might be asymmetrical. These atypical forms of GBS presentation are in the first presenting feature, but as time progresses, the hallmark features of GBS will definitely come into play. Classical description, there are many variants of GBS, where the pure motor variant accounts for 5 to 70%. There are other variants as well, which correspond to around 20% of the entire incidence. The pure motor variant is very common in children where they have complete motor weakness. There will be no evidence of any sensory signs. Usually on electrophysiology, we'll find an Amman variant. It constitutes around 5 to 70% total GBS incidence. And more commonly in Asia, India, and Bangladesh, it is very common. The pure motor variant of GBS is quite common in children and also in our Indian population. Apart from that, there is a paraparetic variant, which is common in adults, usually has motor weakness, which is restricted to legs. They constitute around 5 to 10%. They usually have an Amman variant, but it is more common in adults and not in children. There are other two important variants of GBS, which are the pharyngeal cervical brachial variant, where they may not present you with the typical ascending paralysis. They may have weakness of bulbar muscles. They may have weakness of cervical and the brachial muscles. They also have a very strong predisposition for respiratory failure, and they also have a very strong association with GT1 antibodies. This is a very typical feature of pharyngeal cervical brachial pattern of GBS, where GT1 antibodies are found in more than 90% of the condition. In adults, they also have this bilateral facial weakness with reduced reflexes and paresthesias, but it is not so common in children. They constitute around less than 5%. Apart from the normal variants of GBS, we also have a very atypical one, where triad of ataxia, areflexia, and ophthalmoplegia. This is called the Miller-Fisher variant. There will be no weakness around 90%. Mind you, they come walking to you with areflexia and ataxia and also ophthalmoplegia. 10% of them might have an overlap with GBS, where the presentation may be Miller-Fisher, and over a period of 2 or 3 days, they progress to a classical pattern of GBS. And this condition is also associated with ganglioside antibodies, especially GQ1B. The strong concentration of GQ1B in the extraocular muscles is responsible for this triad, for this clinical presentation of this triad. Another spectrum, or another fag end of the spectrum, is the Bickerstaff brainstem encephalitis variant, where they might start with the Miller-Fisher variant, but over a period of time, they might develop altered sensorium and pyramidal tract signs as well. They are usually also associated with GQ1B. So the major difference between these two conditions is, one is the sensorium of the child, and two, the presence or absence of pyramidal tract signs. This also has a bearing on the management, whereas Miller-Fisher is usually conservative management, where sometimes IVIG is recommended. If it is a Bickerstaff brainstem encephalitis, if you're very sure of the diagnosis, then corticosteroids play a major role. So in short, based on the anatomical substrates, we'll have few clinical features. The involvement of the motor nerves leads to weakness. Involvement of the large diameter sensory nerves leads to loss of vibration and position sense. They might also present you with paresthesias and also ataxia. Involvement of the roots is a very important connotation for pain. And involvement of the vagus nerve and the autonomic ganglia is responsible for dysautonomia. So to summarize, the clinical presentation of GBS is more of an acute polyradiculoneuropathy and not a pure polyneuropathy. In addition to the typical presentation, there are few soft signs when you see a child with Guillain-Barré syndrome, especially in bedside emergency. One important soft sign is the presence of claw hand or the finger drop sign. This is a very typical one, which was just come into picture over the last 5 to 6 years. This is usually characterized by weakness of the finger extensors. The finger flexors are well preserved in nature, and it is commonly associated with the Aman variant. As you can clearly see, this is how there will be weakness of the finger extensor leading onto a finger drop. A better picture is this. This is how they will present, or this is called the bilateral claw hand, and the claw hand is very typically seen here. This is pre-therapy, and following treatment, the claw hand resolves. The reason behind this claw hand is unclear as of now, but it is a very important tool for clinical diagnosis of GBS, especially in young children who are extremely irritable and a complete neurological examination is not possible. The claw hand or the finger drop sign may also be extrapolated to the toes, where there will be a differential weakness of the toes, and there will be weakness involving flexors of the toe, leading on to bilateral toes pointing upwards. This is another important sign in GBS. My personal favorite is the neck stiffness. The neck stiffness is a very subtle clue for radicular neuropathy. Many a time in children with GBS, the complete evaluation looking for meningeal signs is not done, but it is prominent in more than 30 to 40% of children with GBS. The reason for neck stiffness or meningism is the release of byproducts into the subarachnoid space following this nerve root demyelination. In a normal scenario, as in a child with acute onset weakness, where the differential diagnosis of GBS and the polyneuropathy of secondary to diphtheria is entertained, this becomes a very important clue. Mind you, GBS is a radiculoneuropathy, and so definite evidence of neck stiffness will be present in children with GBS, whereas neck stiffness is not a feature of diphtheria. So this is a very subtle clue to diagnose diphtheritic, post-diphtheritic polyneuropathy from Guillain-Barré syndrome. Another soft sign is papilledema. This is seen in around 7 to 30% of children with GBS. This is the implication here is the edema of the spinal roots leads to decreased absorption of proteins, leading on to raised ICP. So presence of papilledema, presence of meningism, and also presence of bilateral finger drop or uprooting of toes are important soft signs for diagnosis of GBS in children. In addition to the clinical features, at the baseline presentation or at the initial presentation, few baseline assessment is mandatory. One among which is the MRC scoring. The MRC scoring is a grading of muscles for a select group of muscles, 3 muscles in each extremity. Usually in the upper limb, we look at the shoulder abduction, elbow flexion, and wrist extension. Whereas in lower limb, we look at hip flexion, knee extension, and also ankle dorsiflexion. So the MRC grading is from 0 to 5. So a maximum score of 60 to a minimum score of 0 will be entertained. This is very important at the baseline level. Why? Reason being, it helps us in 2 important things. One, a difference of 5 or more points gives an objective estimate that there is definite asymmetry between the 2 sides. And more importantly, it is a very important tool to assess the need for respiratory support and plan ICU admission. So at the initial presentation, the baseline MRC scoring is very crucial, not only for the diagnosis, but also helps in prognostication and the need for respiratory support. And at the baseline, one more important scoring is the Hughes scoring, which everybody has to know. This helps us to understand the progression of the disease. This starts from 1 to 6 and 0 to 6, where 0 is healthy and 5 requires assisted ventilation. And a score of 3 or more is considered as severe form of GBS. Another baseline assessment score, which is predominantly used in adults and also in children more than 6 years of age, is the respiratory insufficiency score from Netherlands. This score also helps us to calculate the probability as in which child with GBS will require mechanical ventilation within the first week of assessment. It is based on 3 important parameters. 1, the day between onset of weakness and hospital admission. 2, the facial muscle and bulbar weakness at hospital admission. And 3, the MRC sum score at hospital admission. So based on these 3 parameters, it has been graded from 0 to more than 5. The score of 0 to 2 has a very low risk for mechanical ventilation, whereas a score of more than 5 has a very high risk of mechanical ventilation with a probability of more than 90%. This respiratory function has been used in adults and also in children. It has been validated not only in Netherlands, but also in Japan. So when do you have to have a doubtful diagnosis? So whenever we have fever at the onset of neurological symptoms and the nadir is less than 24 hours, There's a continued progression for more than 4 weeks. There's the sharp sensory level, and also there's marked persistent asymmetry of weakness. Then the diagnosis is under doubt. And there are a lot of differentials to be considered, starting from the neuroanatomical substrates of brain and spine to the muscle. The most important of all will be the anterior hornsel involvement, where acute flaccid myelitis secondary to viral involvement is very common. It usually occurs in clusters. So over a period of 2 to 3 months, we might find a lot of cases of acute viral myelitis, and differentiation from acute viral myelitis with GBS is very important. The differentiation between these factors is beyond the scope of today's lecture. There are a lot of videos on approach to acute. Another important reversible acute flaccid paralysis, a very important differential, is metabolic disturbance like hypokalemia, hypophosphatemia, and hypermagnesemia. So always any child with GBS, the hypokalemia, all these metabolic parameters have to be assessed because these are reversible causes and can be immediately treated. So the diagnosis of GBS is primarily on history and examination, but it is also supported by CSF examination and electrodiagnostic studies. Testing for preceding infections or using levels of anti-ganglion cell antibody levels, they are not going to contribute to the diagnosis, and the utility is quite limited. So as of now, the two main modalities of management with regards to investigations are CSF examination and electrodiagnostic study. The classical finding, as you all know, is albino-psychological dissociation, usually has to be less than 10 WBCs per millimeter cube. And the diagnosis of more and examination of more than 50 cells always points to an alternative diagnosis. When it comes to CSF, a CSF protein of more than 45 is taken into consideration. Mind you, it might be normal in the first week of illness, especially in 30 to 50%. And even the second week of illness, it might be normal in around 10 to 30%. So the important take-home message here is normal CSF protein levels in the first week or the second week do not rule out a diagnosis of GBS. As you can clearly see in this analysis of 494 patients, which included adults and children, over a period of time, there has been an increase in the number of CSF protein levels. By the 7th day of illness, there was 79% positivity for elevated CSF protein. The second important modality of investigation is electrodiagnostic studies. It not only confirms the diagnosis, it also helps us to differentiate between 3 important electrophysiological subtypes. Rather, 2 important electrophysiological subtypes. One is AIDP, which stands for acute inflammatory demyelinating polyneuropathy, and AMAN, which stands for acute motor axonal neuropathy. To understand between these 2 disorders, it is pertinent that we have a look at the pathogenesis of GBS. So the pathogenesis of GBS usually is preceded by infection or an immune stimulation. This leads to an aberrant autoimmune response, which targets the peripheral nerves. So in AMAN, the pathogenesis is quite clear. There has been tremendous progress with regards to the pathogenesis of AMAN. AMAN usually undergoes a form of molecular mimicry between the microbial antigens and the nerve antigens, primarily Campylobacter jejuni. When it comes to AIDP, the pathogenesis is still unclear. We have not progressed over the last 50 years. And the interplay between microbial factors, the host factors, and even geographical factors is still not well understood in AIDP. So we'll start with AIDP. So the first trigger for AIDP starts with an antigen. The antigen is unidentified. This unidentified antigen leads to antibody protection. This antigen-antibody interaction leads to production of autoantibodies, which binds to the myelin. They usually bind to the outer surface of the myelin, as you can clearly see. And this outer surface of myelin binding leads to activation of complement, and this complement activation leads to formation of MAC or membrane attack complex. Following the membrane attack complex formation, there will be vascularization, or the myelin undergoes slow destruction, leading on to macrophage invasion. So as you can clearly see, once the macrophages have invaded, the axon remains intact, but the myelin undergoes slow destruction or segmental destruction. This form of segmental destruction leads to poor conduction along the axon. It disrupts the normal impulse propagation, leading on to increase in distal latency, reduced conduction velocity, and increased F wave. So when we look at a GBS picture electrophysiologically, there are a few technical parameters which you should understand. Following the stimulus, that takes a considerable amount of time following a stimulus to have a proper CMAP. This time duration is called the distal latency. And following the CMAP, the peak of CMAP, we measure it as the amplitude. And the from the starting to the end, we call the duration. So based on these three technical parameters, we analyze our electrophysiological picture. So this is a 6-year-old boy where there was presented with features of GBS. Peroneal nerve was stimulated. As you can clearly see in this, there has been a drop in the, this is the normal parameters for that particular age. Okay. There has been, okay, sorry, there was a small technical fault here. So I'll just go back. Yes, okay. Sorry for the technical glitch. So here, if you look at this particular child, he's a 6-year-old boy with features suggestive of AIDP. The peroneal nerve was stimulated, and this is the normal for that particular age. So we need an amplitude of 2.3, a conduction velocity of 37, and a distal latency of 3.9. And here, as you can clearly see, there has been the latency has been increased. The nerve conduction velocity is also on the lower side, and there will also be evidence of temporal dispersion. So the diagnosis of AIDP is quite clear here because of increased latency and also because of reduced conduction velocity and temporal dispersion. So when it comes to Aman, here we have a pictorial representation of a myelinated axon. A closer view is that at the end of the axon, we have three important parameters. We have the node, paranode, and also the juxtaparanode. When it comes to Aman, the trigger here is Campylobacter jejuni diarrhea. Following the diarrheal infection, there is formation of antigen-antibody interaction. These autoantibodies have a molecular mimicry with the GM1 and the GM2 antigangliosides. These GM1 and GM2 antigangliosides are pretty much common or pretty much rampant in this particular area of the node. So this antigen-antibody interaction happens at the level of the node, leading on to complement activation and also stripping of the axon and leading on to definite evidence of axonal injury. Mind you, here the myelin is purely intact, only the axon is getting affected. So since the axon is getting affected, we have reduced amplitude in 2 or more nerves. We also have a reversible conduction block, and there will not be any evidence of demyelination. This is a classical example. Here we have an 8-year-old boy who had presented with features of GBS. We did a nerve conduction study, and this is the electrographic representation of the median nerve. As you can clearly see, the amplitude is 2.1. where the expected amplitude has to be 5.1. So this drop in amplitude per se indicates that this child is definitely suffering from acute motor axonal neuropathy. The another investigation which has been used recently is the MRI investigation. The MRI investigation is not part of the routine test. It is usually helpful when the diagnosis is unclear, especially in children less than 3 years of age, when there is a strong suspicion of acute viral myelitis as well. And in MRI, we usually find presence of nerve root enhancement. As you can clearly see, this is a pre-contrast and this is a post-contrast, and this arrow particularly shows the contrast enhancement. It's quite non-specific, but more than 95% sensitivity for diagnosing GBS, especially in young children. A word about management. The management of children with GBS has 3 important pillars. One is monitoring, supportive therapy, and also immunotherapy. So all children with GBS has to be admitted. This is primarily to look for evidence of progression. The progression is assessed by MRC grading, also by changing voice, also to look at autonomic dysfunction. A very important factor which also has to be analyzed is the respiratory function. Usually, any evidence of breathlessness at rest, use of accessory muscles, whether there is any abnormal heart rate, abnormal ABG, or ability to count 15 in single breath, all have to be analyzed. All these analysis has to be done every 1 to 3 hourly. This gives a good picture of the progression of the disease in GBS. So not all children require ICU admission, and children with evolving respiratory distress, or there is definite evidence of autonomic dysfunction, or there's rapid progression of weakness, or the IGLIS score, which I already mentioned at baseline, if it is more than 5, then all these children definitely require ICU admission. And when it comes to treatment indications, not all children with GBS needs to be treated. Children who have a GBS disability of more than 3, or in other words, children who are unable to walk unaided for more than 10 meters, and children who are presenting within 2 weeks of onset of weakness, can be treated. Mind you, children who are walking to OPD unaided, but also presenting within 2 weeks of onset of illness do not require treatment. They need only monitoring, look for progression. The two pillars of treatment are one is plasma exchange and IVIG. Plasma exchange was established in 1984. So what exactly happens is it non-specifically removes the antibodies and also the complement. It is usually associated with reduced nerve damage. It also has a very faster clinical improvement. Studies in children as well as in adults and meta-analysis has proven beyond doubt that outcome at 4 weeks, 6 months and 1 year post-exchange was definitely significant when compared to placebo. Hence, plasma exchange is one of the important modalities of treatment in GBS. It is usually useful when started within 4 weeks of onset, 5 plasma exchanges, each exchange of 40 to 50 ml per kg, and usually done over a period of 2 weeks. Another important modality after plasma exchange is IVIG. IVIG is very important, especially when it comes to children. There has been a lot of studies on IVIG and plasma exchange, and what has been proven beyond doubt is when it comes to IVIG treatment, it is at least as effective or superior when it comes to plasma exchange. It usually acts by neutralizing the pathogenic antibodies and also by inhibiting the autoantibody-mediated complement activation. So IVIG is proven to be effective in children who are not able to walk unaided for more than 10 meters. It has to be started within the first 2 weeks of onset of weakness. It usually is given over a period of 5 days, 2 grams per kg. In children, when compared to plasma exchange, IVIG is preferred because of high incidence of dysautonomia with plasma exchange. And in fact, it has replaced plasma exchange as preferred treatment in many well-established centers in the West. One of the major problems with IVIG is with regards to is high cost, which has a very important and resource limited settings like India and Pakistan. The important question that many people ask is that a 5 days or 2 days regimen. So this was a study which was published in Pediatrics in 2005, where 51 children with severe form of GBS, as a GBS disability score of more than 3 were randomized. What they found out was with the 2-day regimen and the 5-day regimen, there was no significant difference in the recovery rate. The recovery rate was almost the same. But more importantly, children who had received the 2-day regimen had a very high incidence of treatment fluctuations, which was in the tune of 21%. And no treatment fluctuation was noted in children who had received IVIG over a period of 5 days. So, despite no significant difference in recovery, I would strongly prefer to give IVIG over a period of 5 days because treatment-related fluctuations are quite less, and it also gives us a lot of opportunity to assess the progression of the disease. Other modalities which they have tried but not found to be beneficial are oral steroids, intravenous methylprednisolone, plasma exchange followed by IVIG, and also eculizumab. Eculizumab was found to be useful because of its complement-mediated activation.
Excuse me, Anand sir, just take it. The slides are not moving, I think.
Okay. Now, is it moving?
Yeah. Right.
So when it comes to complications, we also have to look at few complications of GBS, both in ICU and also in our pediatric neurology ward. They have a very high incidence of hospital-acquired infections. We also have to be a little alert for choking episodes. We also have to be alert for pain and tactile allodynia as well. So this is a normal clinical course of children with GBS, but sometimes there will be few hiccups with the clinical course. One important hiccup is this treatment-related fluctuation. 10% of patients treated with IVIG or plasma exchange deteriorate with time. This usually occurs in the first 8 weeks after start of treatment. Usually, we define treatment-related fluctuation based on the MRC score or at least by the GBS functional score. Whenever there's a stabilization of the course in more than 1 week, following which there has been a drop in MRC subscore by 5 points or a drop in the GBS functional score by 1 grade, then treatment-related fluctuations have to be strongly considered. The underlying hypothesis is unclear, but what has been mentioned is the pathogenic process, though initially suppressed by the treatment, is still active or reactivated, and the treatment effect has worn off while the inflammatory phase is still ongoing. So in general, retreatment is generally recommended, but there is no major evidence for this. Another important hiccup with regards to management is following the first dose of IVIG, around 20 to 30% may not improve in the first 4 weeks of treatment. This poor response usually does not equate to ineffective treatment, whereas it just means that the progression of the disease will be worse if there was no therapy. Usually a second dose of IVIG is provided in such children and adults, and usually after a time gap of 10 to 14 days of first dose. This is also not evidence-based, and there was one particular study which had looked into it. This was including both adults and children. This was the International GBS Outcome Study over a period of, it spanned over a period of 9 years. Almost 20 patients received a second dose of IVIG in the first 2 weeks, and 18 received from 3rd to 4th week. And the primary endpoint was GBS disability at 4 weeks. But despite giving second dose of IVIG, there was no significant difference in the outcome. So the final word of mouth is still not clear. We still have to go for further prospective trials to assess this particular condition. As I initially started, one of the major misconceptions with GBS with regards to is the good prognosis. The mortality rates in the best of centers is from 3 to 7, but in mortality rates without treatments around 20 to 30%, which is quite high. And 80% recover by 6 months, but 20% do not do so and experience long-term problems. Major long-term problems are with physical function, which where exercise programs, especially cycling and walking, is advised. And another important morbidity is fatigue, which is unusually high in the tune of 60 to 80%. So a graded supervised exercise program is definitely recommended so that the range of motion is active. Pain is a quite under-recognized morbidity in children and adults with GBS. Almost 1/3 tend to suffer even after 1 year of onset of disease up to 10 years. This is probably secondary to persistent damage to the small nerve fibers, and we should generally advise mobilization in drugs like gabapentin and carbamazepine. Another one, which especially when it comes to adolescents and also adults, is depression, because of rapid loss of physical function can be quite traumatic. So providing accurate information on the chances of recovery helps them to alleviate this fear. So far, I have discussed what is the theory of GBS. It is more of a didactic lecture. So I would just like to conclude my presentation with what has been practiced worldwide. So I'm going to present the principal trends with regards to the International Guillain-Barré Syndrome Outcomes Study. This included 1,300 adults and children. It started in 2012 and is still going on. Almost 19 countries are included, and from Asia, China and Bangladesh are highly represented here. So based on this, AIDP is the most common subtype worldwide. And when it comes to Bangladesh, the Amman variant was predominantly seen. Patients with mild GBS, where the GBS disability score is less than 3, usually did not receive treatment. But whoever had BP fluctuations or autonomic instability after monitoring were given treatment. Despite the fact that plasma exchange and IVIG are equally effective, 84% had received IVIG, and the dosing of IVIG is 2 grams per kg over 5 days. So the primary treatment option for GBS as of now is the IVIG protocol. And almost 32% had shown no improvement after IVIG, and so 66% of those had received the second dose of IVIG after a median period of days. Though the evidence is unclear as of now, requiring a lot of prospective studies, based on these principal trends, we can fine-tune our management. And finally, the treatment-related fluctuations were seen usually after a period of 23 days, and was seen only in around 5% of this population. Thank you.
Thank you, Anant, for this very comprehensive talk on GBS. Since we are running out of time, I will pick up some of the very pertinent questions that have been put in the chat box for you to respond. So one question is regarding the timing of lumbar puncture. Would you want the timing of lumbar puncture to be delayed into the second week of illness, or is it dependent on the clinical presentation?
So the timing of lumbar puncture, the pickup rate of lumbar puncture, especially to find out elevated CF protein, is high in the second week. But waiting for second week, I would not advise. We can do it in the first week itself, because almost 50% we will find an elevation of CSF protein. One, and number two, even if the CSF protein is not elevated, other parameters like electrophysiology measures will definitely give us the diagnosis. So it is pertinent that we do the lumbar puncture in the first week of illness as the child presents to us.
Right. So basically, a normal CSF actually supports the diagnosis of GBS. So one more question was that why in some patients you have the muscle stretch reflexes spared?
Okay, this muscle stretch reflexes or hyperreflexia or intact reflexes is usually seen in Amman variant of GBS, more importantly, when compared to AIDP. And what has been mentioned is with regards to the antibody interaction, that is the ganglioside antibody interaction at the level of the roots. This was one of the hypothesized one, leading on to, there is this hyperinitiation at the level of nerve roots, leading on to pyramidal tract signs. The inhibition is, disinhibition happens because of this interaction, leading on to exaggerated or intact reflexes.
Okay, so there are 2-3 related questions. Most of them are on treatment. And so first question is, how soon do you start seeing improvement after IVIG? And how do you differentiate treatment-related fluctuation with a child, in a child, vis-a-vis development of CIDP? And when do you consider a repeat dose of IVIG in those who do not respond?
Okay, I'll start with the third question. The third question is usually the second dose of IVIG is usually given based on evidence and also literature search is usually after a period of 2 weeks. So 10 to 14 days is the time which they take for definite evidence of improvement. So that also answers your first question. So clinical improvement usually happens by by the end of first week. So in case there is no improvement at the end of 2 weeks after giving IVIG, then probably we can go for a second dose of IVIG. And with regards to the second question, treatment-related fluctuation from CIDP, CIDP will be dealt in detail by Dr. Hansa. But treatment-related fluctuations are very common in GBS, around 5 to 10%. Treatment-related fluctuations, usually 1 or 2 treatment-related fluctuations can happen. So in case there are more than 3 treatment-related fluctuations, 1, or the treatment-related fluctuation happens after 8 weeks of onset of illness, 2, these strongly indicate that we are probably dealing with CIDP rather than GBS.
Okay, thank you, Anant. I don't think we'll be able to take up all the questions, and maybe you can reply in the chat box to some of these questions. We are running short of time, and we'll move on to the next talk. So our next speaker is Dr. Hansashri Padmanabhan. She is assistant professor in the Department of Neurology at NIMHANS, Bangalore. She's an alumni of PGI Chandigarh and has authored more than 40 PubMed Index publications and also has several chapters in textbook. She has been invited speaker to national conferences, and her primary areas of interest are autism, cerebral palsy, and neuromuscular disorders. So over to Hansa for her talk on CIDP.
Sorry for the delay. Good evening, everybody. First of all, I would like to acknowledge the organizers, Dr. Inder and Dr. Pratik, for giving me this opportunity to speak on CIDP. And it's my privilege to present in front of my teacher, Professor Naveen Sankyan. And I also would like to congratulate the previous speaker, Dr. Anand Narayan, for covering an extensive topic very concisely and very good manner. So I would be covering today about chronic inflammatory demyelinating polyradiculoneuropathy. So my objectives are, at the end of the presentation, I would want at least you people to understand when do you suspect CIDP and how do you differentiate it from acute onset CIDP from acute inflammatory demyelinating polyradiculoneuropathy, and how to differentiate it from inherited neuropathies, and what are the recent developments in CIDP. So starting off with the case scenario, a 10-year-old boy who was developmentally normal, he presents with subacute onset of weakness of lower limbs of 15 days duration, with difficulty in walking, with recurrent falls, difficulty in getting up from squatting posture. And subsequently, he developed weakness progressed to involve the upper limbs, where he had difficulty in reaching for objects overhead and to hold things and to reach for various objects. Symptoms progressed, and the maximum deficit was seen on 45 days from the onset of illness. There was no history of any ocular, bulbar, or facial weakness, no history suggestive of any sensory or autonomic symptoms or any bowel or bladder involvement. Examination, cranial nerves were normal, and the single breath count was 30, which was normal, and chest expansion of 5 centimeters, which was normal. He had a proximal predominant pure motor weakness, predominantly in lower limb than upper limb, had generalized areflexia with a normal sensory examination. Investigation showed a CSF of no cells and a protein of 245 milligram per deciliter, and electrophysiology showed motor sensory polyneuropathy of demyelinating pattern. So as a previous speaker has already emphasized, that in GBS or in acute inflammatory demyelinating polyneuropathy or Amman variant, the weakness is maximally reached by around 4 weeks, as we know the course of the GBS graph. So in this patient, the peak was almost in the 45 days. It was almost 6 weeks since the onset of weakness, and it has been progressive. So is it CIDP? So if it is CIDP, what exactly is CIDP? So CIDP is an acquired immune-mediated autoimmune peripheral neuropathy. Though small, though rare, it is one of the comprises of important subset of treatable chronic childhood polyneuropathies. Initially described by Austin et al., but subsequently detailed characterization and the term chronic inflammatory polyradiculoneuropathy was introduced by Dick et al. In 1975. Typically, it presents either as a relapsing or a progressive neuropathy with proximal and distal weakness, which develops over at least an 8-week period. Moving on to epidemiology. It can present any time between infancy to late adulthood. There are various case reports even in infants. However, the peak is commonly seen between 5th to 6th decade of life, and it is less common in children than adults. The mean age of childhood onset CIDP is around 8 to 9 years. And there is no general predilection. Unlike GBS, where males have more prominent symptoms than females, there is no general predilection is observed in childhood CIDP. The annual incidence rate is also 10-fold less as compared to GBS. It's around 0.06 per lakh per lakh per year in less than 15 years, whereas in GBS it's around 0.13 per lakh per year. The prevalence rate varies to be between 1 to 2 per lakh, with disease prevalence increasing with the age. So what is the pathogenesis of the CIDP? So autoimmune disease, it's an autoimmune disease resulting from loss of immunological self-tolerance. Both cellular as well as humoral immunity act synergistically to cause damage to peripheral nerves. Molecular mimicry, as implicated in GBS, has also been implicated in CIDP and is believed to be the mechanism underlying autoimmune attack. Around 1/3 of the children point towards an inciting or antecedent event, unlike GBS, where 2/3 of the children point towards an inciting event. As we can see, there's demonstration of both autoreactive T as well as B lymphocytes, autoantibodies, and complement-mediated lysis occurs even in CIDP. Whenever there is an antigen being present to antigen presenting cells, and there is stimulation of the T cells, there is breakdown of the nerve-blood barrier, and release of the cytokines and chemokines, activation of the complement-mediated factors, and complement-mediated lysis occurs, especially in the nodal as well as in the paranodal regions. The proteins implicated are neurophysin and contactin in the paranodal regions, and the nodal proteins are neurophysin and clyometine. What you will exactly see in the pathology? You will see reduction in the myelinated fiber density. You would be seeing demyelination, inflammation, and onion bulb formation because of chronic demyelination and demyelination pattern. There is formation of onion bulb, should be seen in electron microscopy. The other characteristic features are endoneural inflammation as well as epineural inflammation, which is seen in both relapsing as well as progressive conditions. Nerve biopsy can be used as a supportive histological criteria, not exactly mandatory, but useful especially in doubtful cases. As we can see, it's an electron microscopic picture showing a macrophage-mediated demyelination, and there's a picture which is showing a thinly demyelinated nerve, and there's a picture which is showing onion bulb appearance in a patient with nerve biopsy of CIDP. There's electroimmunofluorescence, which is demonstrating autoantibodies attacking the nodes of Ranvier and the paranodal region, but you cannot see it in a normal patient. So before we know how a child with CIDP presents, we should keep in our mind always that if the child exhibits necessary clinical features to meet the diagnostic criteria for CIDP, if the duration of symptoms are chronic, to ascertain if child exhibits any features of CIDP mimics. So how exactly they would present? They would present with progressive symmetrical motor and sensory involvement. Proximal limb weakness is almost as severe as distal limb weakness, indicating a non-length dependent neuropathy. Both upper and lower limbs are affected, where legs are affected more commonly than arms. Gait impairment, recurrent falls, and clumsiness are the most common clinical feature. And gait ataxia is another common feature. It is because of the large fiber involvement and leading to large fiber sensory involvement leading to gait ataxia. Hyporeflexia or absent reflexes is the rule, and muscle wasting is rarely pronounced in CIDP. Sensory symptoms like paresthesias and hyposthesias are commonly seen in 65% of the patients, implicating large fiber involvement, and bowel or bladder involvement is not seen in CIDP. What are the uncommon clinical features? These are the uncommon clinical features reported in the descending order. So the back pain and the limb pain is rarely seen in less than 30% of the population, and the cranial nerve involvement is also seen only in 10 to 15% of the population. So enlargement of the peripheral nerves, thickening of the peripheral nerves, papilledema because of increased protein secretion and decreased absorption, and rarely we will see respiratory failure or autonomic dysfunction. So what is the temporal progression and course of the disease? Most of the time, majority present with insidious onset, and 60% of the patients demonstrate the maximal weakness with at least an 8-week period, and 20% demonstrate an subacute onset within 4 to 8 weeks, and another 20% demonstrate an acute onset less than 4 weeks, like AIDP. So childhood CIDP majority will have a relapsing remitting course in 60 to 70% of the children. Another 30 to 40 will have a protracted monophasic course, unlike adults where the monophasic course is prominent. So when you think of CIDP, what are the differential diagnoses which should come up in your mind? Definitely acute onset CIDP has to be differentiated from AIDP, which I'll be dealing it subsequently, and any of the intracranial or spinal cord lesions, anti-horn pathology like spinal muscular atrophy, but definitely muscle weakness or wasting is prominent in spinal muscular atrophy with intact sensation. HSAN, as already previously described yesterday, you'll see painless ulceration, laceration, or self-mutilation. Vasculitic neuropathy will be asymmetrical and painful. Charcot-Marie-Tooth disease will have inherited neuropathy will have a family history of polyneuropathy and Pescavers, and peroxisomal disorders will have prominent cerebral ataxia and retinitis pigmentosa. Leukodystrophies can have this progressive demyelinating pattern of neuropathy with weakness, but they'll also have central nervous system involvement, and mitochondrial disorders can have multisystemic involvement, and CTX will have additional features like tendon xanthomas and cataracts. Before I move on to the diagnostic criteria of CIDP, we should know what's the role of electrophysiology in diagnosing in CIDP diagnosis. So the main thing is the electrophysiology provides us an insight into the integrity of myelin and axons. It's valuable to distinguish between the effects of primary demyelination and primary axonal loss, and helps in differentiating between CIDP and primary axonal neuropathies, and also between hereditary demyelinating neuropathies. What are the parameters we see in CIDP? We see conduction velocity. So as we can see, conduction velocity is a measure of the speed of the fastest conducting motor axons in the nerve being studied. It's calculated by dividing the distance traveled by the nerve with the conduction time. So normal conduction velocity in the upper limbs is around more than 35 meter per second, and the lower limbs it's around more than 30 meter per second. Conduction block. Whenever there is a patchy demyelination, there will be a block in the conduction from the proximal stimulation to the actual nerve side. So this results in a decrease in the amplitude and area of the graph. So as we can see, whenever the distal stimulation, the amplitude is normal, whereas in proximal stimulation, there is a more than half reduction in the amplitude as well as dispersion of the graph, which is suggestive of a multifocal or a patchy demyelination. Similarly, temporal dispersion is because of the different firing rates of the of the nerves because of demyelination. And the distal latency has already been explained. It is a time in milliseconds that takes the impulse to travel from the stimulation point to the wrist to the recording electrode. And FA persistence and minimum latency is also one of the important feature to be seen in CIDP. F wave is a wave recorded from the foot muscles, and it is on the late reflex, which occurs after MUAP. And usually, the normal minimum F wave latency in upper limb is 25 to 32 milliseconds, and the lower limb is 45 to 56 milliseconds. So, what are the abnormalities which you see in CIDP is suggestive of an acquired multifocal and non-uniform demyelination is reduced conduction velocity, prolonged distal latency, and F waves reduced persistence of prolonged latency. We'll see conduction block and abnormal temporal dispersion. So, diagnosis of childhood CIDP. Unlike adults, where there are more than 15 diagnostic criteria which have been proposed, in children we are following a single diagnostic criteria proposed by Nevo and Topaloglu et al. It was last revised in the 88th European Neuromuscular Center International Workshop on Childhood CIDP in 2002. And based on this, we can divide it into a diagnosis of possible or confirmed CIDP can be made. The clinical presentation is variable, with symptoms of neuropathy lasting more than 4 weeks due to underlying demyelination process. And this can be confirmed by electromyography, nerve conduction, or sural nerve biopsy. So MR neurography is not included in childhood CIDP diagnostic criteria, unlike adults. What are the components of childhood CIDP criteria? It includes a mandatory clinical criteria and a major laboratory features. The major laboratory features, we have electrophysiology criteria, CSF criteria, and nerve biopsy criteria. Based on the number of criteria fulfilled, we can classify it further as confirmed or possible CIDP. The mandatory clinical criteria includes progression of muscle weakness in proximal and distal muscles of upper and lower extremities over at least 4 weeks, or rapid progression followed by relapsing or protracted course. And it has associated with areflexia or hyporeflexia. And the electrophysiological criteria includes must demonstrate at least 3 or 4 major criteria in motor nerves, or 2 major and 2 supportive criteria. The major criteria includes the presence of conduction block or abnormal temporal dispersion. We say it as conduction block when there is more than 50% drop in negative peak area or peak-to-peak amplitude of the proximal CMAP if duration of negative peak of proximal CMAP is less than 130% of distal CMAP duration. Temporal dispersion is abnormal if duration of negative peak of proximal CMAP is more than 130% of distal CMAP duration. Reduction in conduction velocity, less in 2 or more nerves, you have to identify less than 75% of the mean minus 2 standard deviation conduction velocity value for age. Similarly, prolonged distal latency in absent F waves or prolonged F wave minimal latency in 2 or more nerves belongs to a major electrophysiological criteria. And the supportive criteria includes absent median sensory, that is sural nerve sparing pattern, absent median sensory nerve action potential where the sural nerve snap is normal, abnormally low terminal latency index, and side-to-side comparison of motor conduction velocity showing a difference of more than 10 meter per second between the nerves, suggestive of a demyelinating pattern. And the CSF criteria includes presence of protein more than 35 milligram per deciliter and cell count of less than 10 cells per millimeter cube. More than 10 cells, it suggests it's against a diagnosis of childhood CIDP. The nerve biopsy features predominantly suggestive of demyelination. It's valuable more in atypical presentation or when electrodiagnostic criteria are not met. Before we proceed, we must know the exclusion criteria. We have to exclude clinical features or history of hereditary neuropathy or other disease or exposure to drugs or toxins known to cause peripheral neuropathy. Laboratory findings, including nerve biopsy or genetic testing that show evidence of a cause other than CIDP. Electrodiagnostic features of abnormal neuromuscular transmission, myopathy, or anti-horn cell disease. So based on these mandatory clinical as well as laboratory features, we can have a confirmed CIDP or a possible CIDP. Confirmed CIDP, we say when there are mandatory clinical feature plus electrodiagnostic and CSF features are present. Possible CIDP when one of the three laboratory findings are present. To summarize, we have a mandatory clinical criteria and laboratory features including electrophysiology criteria, CSF criteria, and nerve biopsy features. And we can confirm it, we can diagnose it as confirmed CIDP or possible CIDP based on these findings. So coming back to our index case, She had a chronic progressive illness, like as you people remember, the maximum weakness was on the day 45. It was almost around more than 6 weeks, suggestive of progressive monophasic course. And she had generalized A reflex on examination. We did the nerve conductions, which was showing this is a conduction of a right median nerve. You can see here the right CMAP stimulated at the wrist. It is showing an amplitude of 4.35, which is almost normal for that age, whereas when we stimulate in the antecubital fossa, the amplitude is around 2.31. It's almost half the amplitude of the distal stimulation, suggestive of a conduction block. And also the conduction velocity is 12.7 in the upper limb, suggestive of a decreased conduction velocity. Similarly, the conduction blocks were seen in the posterior tibial nerve, along with temporal dispersion of the grafts and prolonged distal latency of around 14.95 and conduction velocity of less than 30 milliseconds, around 11.9, 12.3, suggestive of a demyelinating pattern, and F waves were absent in this patient. So, and CSF also show protein of 213 milligram per deciliter. All this fulfill the criteria of CIDP, and we made a final diagnosis of CIDP in the index child. So, what are the ancillary investigations in CIDP apart from the nerve biopsy and the electrodiagnostics in the CSF, which have been not included in the diagnostic criteria? We have ultrasonography now, MR neurography, and autoantibodies. So, ultrasonography now in CIDP, Padau et al. Describes 3 different classes of sonographic findings which correlate with the disease duration. In CIDP, basically what they're trying to do is ultrasonography now, they're trying to study the echogenicity, cross-sectional area of the nerves in various neuropathic disorders, including CIDP, hereditary neuropathy, or entrapment neuropathies. And based on this, they're trying to differentiate between the various inherited or the acquired neuropathies, and specific criteria have been given, and there are also ultrasound scores to differentiate between various kind of neuropathies. So in CIDP, Padau et al. Has described 3 classes based on correlating with the clinical disease itself. So basically there'll be thickening of the nerves, which will be seen, and there'll be increased cross-sectional area with hypoechoic vesicles in the class 1, and increased cross-sectional area with mixed hypo and hyperechoic vesicles in the class 2, and normal cross-sectional area with hypoechoic vesicles in the class 3, with almost treatment has been given, so the cross-section has become normal in the class 3. Apart from the increased cross-sectional area, we'll also see the hypervascularity, and also non-uniform thickening of the nerve will suggest a CIDP, whereas homogeneous thickening will suggest an inherited neuropathy. This is a patient with the chronic CIDP. This you can see ultrasonography showing a median now in the upper arm as well as in the forearm. The chronic CIDP, we can see that the cross-sectional area is almost increased around 55 meters square, and also it's around 30 meters square, and it's uniformly increased both as well as the upper arm and in the forearm, whereas an acute uniform thickening of the median nerve. And in the acute onset CIDP, what I would like to emphasize is, you see in the upper arm, it's almost 16.4 centimeters square per meter square, and in the forearm it is 9.7 meters square, suggesting a patchy demyelination, suggesting a difference between the proximal as well as the distal cross-sectional area, suggesting patchy demyelination. So other thing which we can think of is the MRI in CIDP, thickening in the spinal nerve roots and the peripheral nerves, especially in the lumbar and the brachial plexus, are characteristic features. So we'll have thickening of the brachial plexus, lumbar plexus, and the spinal nerve roots in the MRI, in the MR neurography in CIDP. In one of the largest study, where 38 patients with CIDP was studied by Forgeot et al., he showed increased nerve signal intensity was present almost in 100% of the patients, and nerve enlargement was present in 91%, and contrast enhancement was seen in 36% of the patients. These are some of the images which will be seen in a patient with CIDP. As you can see, there are the thickened brachial and the lumbosacral plexus of the nerve roots, trunk, and divisions. And here we can see the thickened lumbosacral plexus and as well as the sciatic nerve. And also there will be thickening of the cauda equina along with contrast enhancement. And you can see in this cross-sectional axial image, before the gadolinium enhancement, you will not unable to appreciate anything, but after gadolinium enhancement, you're able to appreciate the spinal nerves, suggesting an active inflammatory process, giving a clue to a CIDP. The other important thing which is going on is the autoantibodies which are being discovered, especially the neurophysin, contactin, Casper, and myelin-associated glycoprotein and GM1 proteins. This prevalence is only 5 to 10% of the population, and the frequency is very less. More antibodies are still being discovered, and they're trying to do a phenotype correlation with antibodies that have been discovered. So after reviewing the literature, we went back to our case and we got an MRI plexus scan. And as we can see, there is symmetric thickening. There is symmetric thickening with T2 hyperintense signal of the roots, trunks, and division of the brachial plexus, and T1 weighted gadolinium enhancement shows mild diffuse enhancement of the bilateral brachial plexus. So moving on to the case scenario. So now we have understood the clinical features and the diagnostic criteria of CIDP and the other ancillary investigations like MR and the ultrasonography. So moving on to case scenario 2. So we have a 12-year-old girl who presented with acute onset of weakness of all 4 limbs of 7 days duration. And she also had paresthesias in the form of tingling and numbness noted in the feet, and there was no bowel or bladder involvement, and onset to maximal deficit was 2 weeks. So on examination, there was proximal and distal weakness was there, and 2/5 in both upper and lower limbs. There was generalized areflexia and mute plantars. Impaired joint proprioception and joint position sense was there on sensory examination. There was no sensory level, ocular, facial, or bulbar or facial weakness, or no respiratory weakness was present. So how do you differentiate? As we all know, that 20% of the patients of CIDP can present in an acute manner, that is within 4 weeks, just like AIDP. So how do you differentiate AIDP versus acute onset CIDP? So what are the similarities in both AIDP and CIDP is, both will have CSF albuminocytological dissociation, and the histopathology will show multifocal inflammatory demyelination in both, and both the pathophysiology has been hypothesized to be because of the molecular mimicry and autoimmune nature involving both humoral as well as cell-mediated immunity. So what are the predominant features pointing towards the AIDP when a child presents with 4 week duration, less than 4 weeks of acute flaccid paralysis picture? In AIDP, preceding infection is obvious in around 2/3 of the patients, usually monophasic course, and it doesn't respond to steroids, and there'll be no nerve thickening on ultrasound or MRI, and cranial nerve involvement will be there usually, and autonomic dysfunction and respiratory involvement is very common. In acute onset CIDP, preceding infection is present in only 1/3 of the population, and it's a chronic progressive illness. And most commonly, we see relapsing remitting course, and they show good response to steroids, and nerve thickening demonstrated in ultrasound and MRI, and cranial nerve, autonomic dysfunction, and respiratory involvement are rarely present. And patients usually maintain the ability to walk in spite of having the severe disease. So one of the study by Raj et al. Published in Neurology in the year 2010, they did a study to differentiate between acute onset CIDP from fluctuating Guillain-Barré syndrome. It was a prospective study, and they concluded that we should suspect CIDP in a patient who considered to have GBS if they deteriorate again after 8 weeks from onset, or when deterioration occurs 3 times or more. This question has already been answered by Dr. Anand. It was asked, like, how do you differentiate treatment-related fluctuations from CIDP? Whenever there are more than 3 treatment-related fluctuations, or there is a deterioration more than even after 8 weeks, you should think of a CIDP. And especially when the patient remains able to walk independently and has no cranial nerve dysfunction or electrophysiological features likely to be compatible with CIDP. So maintenance treatment for CIDP should be considered. So moving back to a case scenario. So our child, initially she was managed as AIDP as she presented with 7 days duration with 5 cycles of plasmapheresis. 4 weeks she came with complete recovery with no residual deficits. But however, at 6 weeks, she presented with new onset weakness in the lower limbs with power of 1/5 in the proximal lower limb and 3/5 in the distal lower limbs. Possibility of TRF was considered, or recurrent GBS was considered initially, and she was treated with IVIG 2 grams per kg over 5 days. However, at 3 months, she presented with the third relapse and confirming the diagnosis of CIDP by her clinical presentation, and also the investigations were conclusive of CIDP. So the next question is, how do you differentiate between inherited neuropathy from CIDP? So in CIDP, The proximal limb weakness is almost as severe as the distal limb weakness, indicating a non-length dependent neuropathy, unlike inherited neuropathies, which will be length dependent, and distal weakness will be predominant as compared to the proximal weakness. And muscle wasting is rarely pronounced, but in inherited neuropathy, muscle wasting will be very much pronounced. There will be presence of autoantibodies in CIDP. In inherited clues for the inherited neuropathy includes a family history of polyneuropathy, or skeletal markers like PES chaos on examination, and they'll have a uniform slowing in conduction, unlike CIDP, where there'll be conduction block and multifocal demyelination. And there'll be lack of response to the immunomodulation. So ultrasonography now and MR neurography may help in differentiating both of them by using various scores which have been proposed, but still they are under research purposes. And genetic analysis would confirm inherited neuropathy if there is no further response to treatment. If they present like a CIDP picture and there is no further response, and you can do a genetic analysis which would confirm an inherited neuropathy. All said and done, but there'll be a considerable inherited neuropathies with these genetic mutations where they'll have a clinical overlap of presentation with both CIDP as well as inherited neuropathies, and they can mimic CIDP sometimes, but ultimately non-response to the immunomodulation and some of the characteristics in MRI or ultrasonography in the genetic analysis may further give clue to the diagnosis. One must remember there are certain variants, like in GBS, there are many variants. In CIDP, variants have been described predominantly in adults. The most common variants are like distal acquired demyelinating sensory motor neuropathy. It's predominantly distal involvement, and sensory is motor more than motor, and may have ataxia as a manifestation. You have a multifocal CIDP or Lewis Summers syndrome or MATSAM variant, where you'll have asymmetric onset. Usually CIDP is symmetric proximal and distal weakness. In MATSAM, we'll have asymmetric motor and sensory neuropathy. And in motor CIDP, proximal and predominantly motor involvement will be there, and sensory CIDP predominantly sensory involvement will be there. So when do you have to think of alternative diagnosis? You have to think of alternative diagnosis whenever there is prominent pain symptoms or significant early muscle aching or no or symptomatic sensory disturbances or minimal sensory disturbance or comorbid conditions or other systemic features, especially in adults, especially diabetes. Adults, you have a multiple associations and comorbidities which you have to think. I'm just focusing on kids. Whenever you have probably another CNS involvement in history or retinitis pigmentosa on examination, presence of sensory level and cranial nerve involvement, respiratory muscle involvement, and autonomic involvement or sphincter disturbances, cognitive impairment, and failure to respond to adequate trials of treatment, all this should make you think of an alternative diagnosis. Moving on to the treatment, the main goals of treatment are controlling the inflammation and preventing from axonal degeneration, and reducing the symptoms and improving the functional status and maintain long-term remission. As per the Cochrane review, the first-line therapy are IVIG, steroids, plasma and plasma exchange. And in the second line, we have immunosuppressants and cytotoxic drugs like azathioprine, cyclosporin, cyclophosphamide, interferon, and many more, but with a low-quality evidence. The first line treatment in childhood CIDP is IVIG. So most commonly in the studies, actually pediatric CIDP, we don't have a large cohort or a RCT is not done. It's more the interpretation has been taken based on the retrospective case series and cohort anecdotal data. It has been anecdotal case reports. From there, the interpretation has been drawn. One of the person who has studied CIDP in pediatric CIDP is McMillan et al. He has published a case series of 30 patients of his own and reviewed all the previous literature, which comes to a total of around 143 cases. In his cohort, IVIG was the most commonly used drug, and it showed remission at around 90% of the children. And the dose which was used as we use in GBS, initially we have to use around 2 gram per kg per day, 2 gram per kg over 2 days. And as an initial dose, followed by maintenance, every 3 or 4 weeks, we have to give a maintenance for around 1 gram per kg, and subsequently gradually increase the duration of, maintenance, initially around 3 to 4 weeks, and subsequently 4 to 5 and 5 to 6 weeks over a period of a year, and gradually taper and stop. And we cannot exactly tell, till how long do we have to continue. It all depends upon the clinical improvement, clinical course of the child. Normally, they have seen, usually they usually come up between 6 months to 1 year, but it still can go up till 4 years also. The side effects of IVIG include headache, fever, and nausea, vomiting, anaphylaxis, and renal failure. The other first-line treatment is corticosteroids. It is shown to be, improvement has been shown in 75 to 100% of the children. Only disadvantage with steroids is the side effects. We cannot use it on a chronic long-term basis because of the osteopenia, growth suppression, cataract, or immune compromise. So many side effects with the long-term use of steroids, or we have to add an additional steroid-sparing agent to reduce the side effects of steroids. The dose which we have to give is 1 to 1.1 to 2 mg per kg per day for the initial 4 to 6 weeks, followed by a taper subsequently over the next 3 to 6 months, and addition of a steroid-sparing agent subsequently if there is a good response to steroids. Otherwise, we can give like weekly, high dose steroids and repeat it every 4 weeks, like 2 mg per kg per day, or we can also give 2 mg per kg per alternate day. So in our institute, they usually give intravenous methylprednisolone, pulse steroid course every month for around 6 months, and subsequently, taper and stop them gradually. Plasma exchange, as we know, it is the first mode of treatment in GBS. We don't have that much evidence in CIDP. As I told, we don't have a large cohort. It is less frequently used because of the procedural difficulties, and the treatment remains the same. We have to do a double volume plasma exchange has to be done and repeated every once in 3 to 4 weeks for a year. But it has a lot of side effects. It requires a large bore catheter and a terminal access, like side effects like hemodynamic instability, sepsis, and lots of issues with plasma exchange and availability and difficulties. And most of the cohorts or the reports what we have in CIDP, IVIG or corticosteroids have been used as the first line of treatment. So when do we have to use an alternative immunosuppressant? So whenever the first line fails, one of the drugs, IVIG, plasma, or steroid fail, you have to try another first line mode before we go on to the subsequent alternative immunosuppressant. So when we have to use the alternative immunosuppressant, the patient has not improved with sequential or combined trials of the conventional therapies. The patient has improved with these treatments but has frequent relapses, usually with attempts at weaning, especially on steroids. They generally tend to have relapse as soon as we are trying to taper it off, or develops intolerable side effects. One of the most commonly used drugs is azathioprine in children at a dose of around 2 to 3 mg per kg per day, and CBC and liver enzymes have to be monitored. But the action, it may take around 6 to 9 months for the action. Another drug for the response, another drug which we use is mycophenolate mofetil, and improvement in successful corticosteroid dosage reduction following therapy with MMF has been reported, and on the onset of improvement it takes around 3 to 4 months for mycophenolate mofetil for its action to develop, and the standard dosage is around 1 gram twice a day. Other immunosuppressive therapy which have already been described. So what are the various outcome measures which people have used for studying CIDP? Is the modified Rankin score has been studied by most of the people. Another thing which has been studied is the CIDP disease activity status scoring. Both have been used for various research purposes, and we have to monitor while we start the treatment before itself to know the progress of the treatment. Prognosis, unlike adult CIDP, childhood CIDP is good with appropriate immunotherapy. The prognosis is good. What are the predictors of outcome? Especially if when we have an atypical CIDP or chronic insidious progression, when we have a chronic progressive CIDP of more than 3 months duration, and electrophysiology showing axonal dysfunction, and immunological features, presence of autoantibodies against neurofilin, contactin, and Casper-1 is predictive for poor response to treatment in CIDP patients. So especially, as I told, the Macmillan et al., which I showed, like 143 cases have been reviewed. And here he says a majority of the children presented like a relapsing course in 70% and monophasic in 30% of the 30% of the children. The combined initial or first-line treatment response was favorable for IVIG in 79% of the patients and corticosteroids in 84% of the patients. And in most of the cohort, they never used plasma exchange, and the response was poor because they haven't tried in this cohort of population, and the outcome was very good and favorable. As we can see, the last follow-up was around 3.5 years from the onset, and the modified Rankin scale score has decreased from 3.7 at onset to 0.7, favoring mentioning a favorable prognosis for most patients, and 45% were off immunosuppressant at the end of 3.5 years. To summarize, it's an important treatable cause of acquired polyneuropathy. Unlike adults, majority have a relapsing remitting course and 16 to 20% present acutely. The diagnostic criteria which we use is revised Nevo and Topaloglu et al. And it's important to differentiate from AIDP, inherited neuropathies, and toxic metabolic neuropathy and other CIDP mimics. IVIG steroids and plasmapheresis forms the first line of treatment. Prognosis of childhood CIDP is favorable than adults, and recent advancements like ultrasound now, immunography, and autoantibodies needs further exploration. I would like to acknowledge my colleagues for the cases and help for providing me the cases of CIDP.
Thank you, Hansa, for that very comprehensive talk. There are a couple of questions which you may like to take. One is specifically in the case you presented. There is a question as to why plasmapheresis was chosen over IVIG in that case.
Because they weren't affordable initially. And we use plasmapheresis in imams as a first-line mode of treatment.
Okay. And the next question is that can MRI finding in differentiating GBS from CIDP?
Yes, like in GBS only there'll be contrast enhancement, but the nerve root thickening and the brachial plexus or the lumbar sacral plexus, which I showed, is primarily seen in CIDP and not in GBS.
Okay, thank you. So I think everyone has to realize is that CIDP is a chronic process, and that it not only is characterized by demyelination, but also several rounds of remyelination. That remyelination leads to thickening of the nerves, and that is what we pick up on the. Whereas GBS is an acute process, you will not see active remyelination, clinically or clinically you may still see improvement, but on the imaging you will see just phase of the demyelination, or rather acute inflammation, which will be characterized by contrast enhancement. The other important thing which is important for CIDP is that the demyelination is patchy, and the velocities, as was the example shown by Dr. Hansa, the velocities at various segments will also vary. If you carefully saw the example, you would see that velocity at some places was 12, some places 24. Whereas in an inherited demyelinating neuropathy or a hypomyelinating neuropathy, velocities will be reduced uniformly across the nerve, and uniformly when you compare side to side, two limbs, or compare upper limb and whole limb. So any other question, Hansa, you want to highlight anything, or maybe Dr. Inder or Dr. Pratik?
Thank you, Naveen sir, and thank you, Dr. Hansa ma'am, and thank you, Dr. Anand sir. Today, both the speakers, they have covered very nicely the topic, and this was, as Naveen sir has already told, this is very important not only to the pediatric neurologist, also to the pediatricians, especially Guillain-Barré syndrome, which is the most common cause of acute flaccid paralysis in our country. And I think it would have been enjoyable to all the attendees. Tomorrow we are going to take another important topic in the sixth session of this neuromuscular update on acquired and congenital myasthenia. So I request all the attendees who have attended today to also participate in tomorrow's session. And lastly, I will also thank all the speakers and chairperson Dr. Naveen sir for the that they have spent their valuable time and made this session a successful one. Thank you, everybody, and good night.
Thank you, sir, for very valuable time. Thank you, sir.
Thank you, Inder. Thank you, Pratik.
Thank you, sir. Good night, sir.